Today I'm going to talk about evaluation of the adolescents with heavy menstrual bleeding. The first thing I'll say is that deciding who truly has heavy menstrual bleeding of a medical concern and who has heavy menstrual bleeding that is subjective can be very difficult. After talking with the patient, it's important to try and figure out who we should evaluate further and who we should simply reassure. Causes of heavy menstrual bleeding are determined mostly based on historical information, which can include the severity of the bleeding, the length of bleeding, timing in between menstrual periods, all of those normal historical elements you would ask. But most importantly, is this the first menses, or is this something that has been going on a long time or progressively worsening over time? I certainly worry a bit more for coagulopathy in those patients where they had a severe bleed during their first menstrual period. While there are some of those patients that will ultimately have a negative workup, patients who are at menarche having a very heavy or prolonged bleed requiring admission and possibly even blood transfusion are very worrisome indeed. So also factors in determining who to get a further evaluation on includes those patients with a family history of coagulopathy, patients who've had other episodes of heavy bleeding. So, for example, with procedures, lots of young people have had a tonsillectomy, and certainly any surgical procedures with a complication of bleeding are noteworthy. Patients with easy bruisability, and that's defined as greater than 2.5 centimeter bruises without obvious causes. Do they have epistaxis or gum bleeding? And certainly patients that have gum bleeding can just simply have that when they brush their teeth if their oral hygiene is poor. But significant gum bleeding is important. Once I figure out who I'm going to study further based on historical elements, if I just am not able to get a good idea of how much blood flow is actually occurring, I want to look for some objective evidence of blood loss. You can try and do this by pad counts, but pad counts are very susceptible to patients' hygiene practices. Some patients will go to the bathroom frequently to check their pad, and every time they go, they will change their pads, so that automatically gives them a high pad count, regardless of whether they're actually having excessive blood loss. But another piece of evidence is containment. Well, what we mean by that is the patient having difficulty controlling her menses and her hygiene to the point where she is soiling her clothes? So containment problems can be explored further. It may be that somebody doesn't change their pads frequently enough, and that's the cause of containment issues. But surely over time, a teenager can certainly learn how to manage that if their flow is really normal. And that's just working with the teenager behaviorally. Other evidence of blood loss is certainly anemia or low ferritin, which is an assessment of iron stores. Then finally, we have the pictorial blood assessment chart, which is a scoring system available, and it has been validated, where on the card we have pictures of menstrual pads or tampons, and there's a picture of a patient with a pad with minimal soiling, more soiling but still some white edges, or a completely soiled menstrual pad. So for each day that the patient is on her menses, she'll record how many of each pad type she had. So she may have 2 here, 3 there, none here. You can also assess clots that are greater than a quarter size. So she may say, well, she's had 1 of those. Or episodes of flooding where large quantities of menstrual fluid come out at one time. So basically you get a score for each one of these. Multiply that times how many the patient had on a given day, add up all of the total days, and that gives you your PBAC score. Depending on which one you use, there will be a cutoff, and above that cutoff you can estimate about how much blood the patient is losing. It's not a perfect system, but it's certainly better than asking patients how many pads they use on a given day. The other thing is these pictures are also available for tampons as well for patients who do that. If you've decided that you need to go ahead and obtain some laboratory studies for the patient, the most important test, of course, is the pregnancy test. Believe it or not, some patients do not tell the truth when asked about their risk for pregnancy. The other thing all patients get is a TSH in order to assess for thyroid abnormality. So you want to assess platelets. And to do that, you get a platelet count on a CBC with a diff. And to assess platelet function, we get a platelet function screen. Now this is a much simpler test than platelet aggregation studies, which require an appointment with the lab. They require that blood be drawn and mixed with different elements in order to determine whether platelets are actually functioning properly. You may remember the good old-fashioned bleeding time. The platelet function screen has now replaced the bleeding time. It's done on a machine called a platelet function assay 100 and is an excellent test for simply trying to sort out patients who have platelet function abnormalities and patients who don't. It's easy for the patient because she can just go and get her blood drawn, and it does not require a more elaborate test such as a bleeding time. And it's also a better test. Certainly we want to assess for anemia, and we do that with our CBC and a ferritin. You can also get an idea of what's going on based on the patient's mean corpuscular volume. Always get a PT, PTT, INR, and a fibrinogen to rule out those hypofibrinogenemias. In terms of radiology, I think if a patient has bled significantly enough to require intervention, they probably deserve a pelvic ultrasound. Now, this can be done transabdominally, does not have to be a transvaginal ultrasound. And while they are fairly low yield, it is an inexpensive test to capture that rare patient who does have a structural abnormality. So hopefully we've reviewed for you which patients we want to evaluate for menorrhagia and which patients we can reassure regarding their menses and simply move forward with counseling on hygiene practices and also expectations for a normal menses. In addition, we know who we're going to do further testing on, and we know what kind of testing we're going to do for those patients so we can manage appropriately.